Good morning, everyone. Myself Prashant Naik. Today we are going to study a topic on measurement of bioavailability and urinary excretion studies. Now, what is measurement of bioavailability? The method useful in quantitative evaluation of bioavailability can be broadly divided into two categories: pharmacokinetic methods and pharmacodynamic methods. Pharmacokinetic methods, these are widely used and based on the assumption that pharmacokinetic profile reflects the therapeutic effectiveness of a drug. Thus, these are indirect methods. The two major pharmacokinetic methods are plasma level study and urinary excretion study. What are pharmacodynamic methods? These methods are complementary to pharmacokinetic approaches, involves direct measurement of drug effect on physiological process as a function of time. The two pharmacodynamic methods involved in determination of viability is acute pharmacological response and therapeutic response. Now, what is plasma level studies? Let us understand this. Unless determination of plasma drug concentration is difficult or impossible, it is the most reliable method of choice in comparison to urine data. The method is based on assumption that two dosage forms that exhibit superimposable plasma level time profile in a group of subjects should result in identical therapeutic activity. With single dose study, the method requires collection of serial blood samples for a period of 2 to 3 biological half-lives. After drug administration, their analysis for drug concentration and making a plot of concentration versus corresponding time of the sample to obtain the plasma level time profile. With the IV dose, sampling should start within 5 minutes of drug administration and subsequent samples are taken at 15-minute intervals. Adequate, adequately To adequately describe the disposition phase at least 3 sample points should be taken if the drug follows one compartment kinetics and 5 to 6 points if the two compartment model it follows two compartment model. For oral dosage form, at least 3 points should be taken on the ascending part of the curve for accurate determination of Ka. It's an absorption rate constant Ka. The point of disposition or descending phase of the curve must be taken in a manner similar to that for IV dose. Three parameters of plasma level studies which are considered important to determine the viability are Cmax, a peak plasma concentration that gives an indication whether the drug is sufficiently absorbed systematically to provide a therapeutic response. It is a function of both the rate and extent of absorption. Cmax will increase with an increase in the dose as well as increase in the absorption rate. Tmax, time maximum, the peak time that gives the indication of the rate of absorption. It decreases as the rate of absorption increases. AUC, what is AUC? Now, AUC is the area under the plasma level time curve that gives a measure of the extent of absorption and the amount of drug that reaches the systemic circulation. Now, let us understand these parameters. The extent of viability can be determined by the following equation: F equal to AUC of standard by dose by test, AUC by test dose of standard. In the case of FR stands for relative viability. AUC by standard, AUC by test, dose by standard, AUC by test, dose by standard, where D stands for the dose administration and subsequently IV as well as oral. So here we are comparing IV versus oral. The route of administration, subscripts, test and the standard indicate that the test and the standard dose of the same drug determine the relative viability. With the multiple dose study, the method involves drug administration for at least 5 biological half-lives, with the dosing interval equal to or drug interval equal to or greater than the biological half-life. That is, administration of at least 5 doses to reach the steady state. So 5 doses should be given, or 5 doses collection should be done to require to reach a steady state of the drug concentration. The blood samples should be taken at the end of previous dosing interval and 8 to 10 samples after the administration of the next dose. The viability is given as FR, AUC by standard, standard by test, AUC by standard, standard D by dose by test. Now, where AUC is the area under the curve in plasma time level curve of one dosing interval in a multiple dosage regime after reaching the steady state, and if the dosing interval viability can be determined from the peak plasma concentration at steady state, we call it as CSS, and then the equation which stands for CSS. From this graph you can see clearly this figure depicts the determination of AUC of CSS max on multiple dosage steady state. You can see here clearly the doses are at least 5 steady doses which has to be given to reach a plateau or a steady state of the formulation. Urinary excretion data. This method of accessing viability is based on principle that urinary excretion of unchanged drug is directly proportional to the plasma concentration of drug. As a rule of thumb, determination of viability using urinary excretion data should be conducted only if at least 20% of the administered drug is excreted unchanged in urine. The study is particularly useful for drug extensively excreted unchanged in the urine, for example, certain thiazide derivatives and sulfonides. Drugs that have urine as the site of action, for example, urinary antiseptic such as nitrofurantoin and hexamine. The method had several advantages and disadvantages. Concentration of metabolite exceeded in urine is never taken into account in calculation since a drug may undergo presynaptic metabolism of different stages before being absorbed. The method involves collection of urine samples at regular interval for a time span of 7 biological half-lives. Analysis of unchanged drug in the collected sample, determination of the amount of drug excreted in each interval and cumulative amount excreted. For obtaining valid results, the following must be met further. At each sample collection, total emptying of the bladder is necessary to avoid error resulting from addition of residual amount to the next urine sample. Frequent sampling of urine is also essential in the beginning in order to compute correctly the rate of absorption. Fraction excreted unchanged in the urine should be seen. Three major parameters examined in urinary excretion data obtained in a single dose study are dxu by dt. Now, what exactly is this? You can see the plot of urinary excretion data versus time, where on the top of the peak you can see dx by dt, and at the base of this you can see tu by max. So, what exactly is dx by dxu by dt? It is the maximum urine excretion rate. It is obtained from the peak plot between the rate of excretion versus the midpoint of the urine collection period. It is analogous to Cmax derived from plasma level studies, since the rate of absorption of drug in urine is proportional to the concentration in systemic circulation. Its value increases at the rate or extent of absorption increases, as shown in the figure. Tu max, the time of the maximum excretion rate, is analogous to the Tmax of the plasma level. Its value decreases as the absorption rate increases. XU is the cumulative amount of drug excreted in urine related to the AUC of plasma level data increases with the extent of absorption. Now, in practice, estimation of viability by urinary excretion study is subjected to a high degree of variability and less reliable than those obtained from plasma concentration time profile. It is thus recommended as a substitute for blood concentration data rather than it could be used in conjugation with the blood level data for confirmatory process. Viability can be determined for a few drugs by assay of biological fluids other than plasma and urine. In case of theophylline, salivary excretion can be used, whereas for cephalosporin antibiotics, appearance of drug in CSF and bile can be determined. Caution must, however, be exercised to account for salivary and enterohepatic cycling of drugs. Acute pharmacological response method. This is one method where viability measurement of pharmacokinetic molecule is difficult, inaccurate, and non-reproducible. An acute pharmacological response effect such as change in ECG or EEG reading, pupil diameter, etc. is related to the time course of a given drug. Viability can be determined by construction of pharmacological effect time curve as well as dose response graph. The method requires measurement of responses for at least 3 biological half-life of the drug in order to obtain a good estimate of AUC. What are the disadvantages of this? The pharmacological response tends to be more viable, variable, and accurate correlation between measured response and drug availability from the formulation is difficult. Observed response may be due to an active metabolite whose concentration is not proportional to the concentration of parent drug responsible for pharmacological effect. Therapeutic response method. Theoretically, the most definite, this method is based on observing the clinical response of a drug formulation given to the patient suffering from diseases from which it is intended to be used. However, the method sorry, has several drawbacks. Quantitation of observed response is too improper to allow for reasonable assessment of relative viability between two dosage forms of the same drug. Bioequivalence studies are usually conducted using a crossover design in which each subject receives each of the test dosage forms and is assumed that the physiological state of the subject does not change significantly over the duration of study. Unless multiple dosage protocols are employed, a patient who required the drug for a dose disease would be able to receive only a single dose of the drug every few days or perhaps every week. Because of the above consideration, the general conclusion is that most bioequivalence studies should be carried out in healthy subjects. Drugs that are not designed to be observed into systemic circulation and are active at the site of administration, clinical studies in patients, are the only means to determine bioequivalence. Such studies are usually conducted using a parallel rather than a crossover design. Examples include studies of topical antifungal agent drug used in treatment of acne. The reference is taken from Shagil, Applied Biopharmaceutics and Pharmacokinetic, McGraw-Hill Education from the year 2016, and Brahmankar and Jaiswal, Biopharmaceutic and Pharmacokinetic, a treatise, 3rd edition, Vallabh Prakash. So today we have learned what exactly is urinary excretion study and viability studies and how it has to be done, what are the conditions to be done. That's all for today. Have a nice day. Thank you.